I'm Dr. Kevin Kavanagh. I'm from HealthWatch USA, and we're a patient advocacy and research integrity organization, and we have been specializing in infectious disease. So during this presentation, we're going to talk about exposure and dosage, aerosolization, ventilation, masking, isolation with references to COVID, MRSA, and unfortunately now measles, enhanced barrier precautions, and also chlorhexidine bathing. So let's talk about exposure and dosage. I really do believe that exposure and dosage is important both in prevention of disease, but also if you acquire the disease, how severe this viral infection will be. Now, exposure is often defined as the ID50 or the level of exposure, where you have a 50% chance of becoming infected. And I look at exposure dosage both with viruses and bacteria. Bacteria usually require a lower exposure dosage because they can divide and live by themselves in the environment. The one exception is probably tuberculosis, which is extremely infectious. With tuberculosis, the ID50 is thought to be less than 10 bacilli. Now, viruses usually require a greater exposure dosage because they are unstable in the environment. They have to, at random, find a receptor to link to and then infect a cell. SARS-CoV-2, which is, of course, one of the current viruses that we're combating, this is felt to be highly infectious and to require less than 100 particles to be exposed to in order to elicit an infection. Now, I should note that I also believe, although there's some evidence, it's not ironclad, that the number of particles you're exposed to in the beginning will relate to the severity of the infection. So if you have one virus that infects a cell and that's what your body's dealing with, that's easier for your body to handle than if there's, for example, 100 or 1,000 cells infected at the onset at the same time. So again, exposure dosage is important, and when you look at source control, ventilation, distance from people, hand hygiene, all of this affects your exposure. There were two interesting articles which dealt with SARS-CoV-2 and exposure dosage. One was from Lind et al., and this article evaluated a prison population. The population was divided into three groups. One without a documented exposure to SARS-CoV-2, another with cell block exposure, and a third with cell exposure. Each group was then subdivided into three sections. One was those inmates which had a prior infection, those inmates which were vaccinated, and those inmates which had hybrid immunity. Now, if you look at the hazard ratios, you can see that as the groups progressed from no documented exposure to a high exposure within a cell, the hazard ratio increased, which signifies an increased chance of getting the infection. You can also note that vaccinations did not provide as strong of immunity as infections, but hybrid immunity was best. Infections, although the immunity was highest, the immunity still waned. As you can see, the chances of getting reinfected with cell exposure, even though you had a previous infection, was almost double. And the hazard ratio of 0.89 is extremely high. It is not much better than that of vaccination. And so again, you want to become vaccinated. Hybrid immunity is best, so if you did have an infection, you still want to get vaccinated. And neither vaccinations nor infections provide you with durable immunity. And it does not provide you with protection that is to the level that you will not want to take other measures. Thus, even though you're vaccinated, even though you've had an infection, you still need to have other layers of protection, such as masking and making sure that you're in well-ventilated indoor settings as opposed to settings with poor ventilation. There was also a recent study in Nature on cell phone tracking data. And again, you need to remember that this is just relational. You really can't take the duration of time it takes to be infected, you cannot put that down as being ironclad because we don't know the mitigation effects which were being used. We don't know the viral concentration these individuals were exposed to. So again, this is just relational, and if you look at the cell tracking data, longer exposures at greater distances had similar risks and shorter exposures at closer distances, and the probability of transmission increases with the duration of exposure. And so this is what's to be expected. Dosage is important, exposure is important. The next concept I want to talk about is aerosolization. And aerosolization has really undergone a paradigm shift over the last several years. The National Academies of Sciences has come out in October of 2020 with a very good manuscript regarding airborne transmission of SARS-CoV-2. And they talked about aerosolization and how we used to think of airborne transmission being divided into either aerosols or droplets. Aerosols less than 5 millimeters, droplets were particles greater than 5 millimeters, and droplets weren't really aerosolized. And we know that this is now in error and it's no longer accepted by mainstream scientists. First, we've realized that particles can aerosolize up to 100 microns. The 5 micron cutoff, it's really not accurate. And not only this, but there's a continuum of particles. And so the droplet aerosol type of demarcation or nomenclature, it really shouldn't be used. Particles are aerosolized, and they can be aerosolized up to 100 microns. Remember, most viruses are around 0.1 microns or smaller. Bacteria is 1 micron. So all of these can be easily aerosolized. Now, when you look at SARS-CoV-2, the viral half-life in aerosols is thought to be about 1 hour, and UV light will greatly decrease viral stability. So anything that you can do in the workplace to increase ventilation, increase filtration, or install UV light fixtures is going to increase the safety of your working environment. Now, this is, I think, a interesting fact, and this kind of gets into actually some disinformation campaigns, is that SARS-CoV-2 doesn't survive well in warm, humid climates. It decreases viral stability, helps to prevent spread. And in poorer countries that do not have air conditioning, they usually keep their windows open. And that further decreases spread. So when you look at countries that are poor, that have warm climates, that are humid, they tend to have less spread of SARS-CoV-2. And of course, they also have malaria. And hydroxychloroquine is widely used to both prevent and treat malaria. This has helped to lead to advocating for hydroxychloroquine as a treatment for SARS-CoV-2. However, this association is not causative, and hydroxychloroquine is not effective for the treatment of SARS-CoV-2 infections. Now, there were 239 experts in the summer of 2020, and this initiative was spearheaded by Dr. Lydia Moroska. And these experts sent a letter to the WHO citing the mounting evidence and the need to consider SARS-CoV-2 an airborne pathogen and to take steps for its mitigation. And this is a graphic from the publication of the letter. It talks about droplets, microdroplets, importance of ventilation, how there's a continuum of droplets. And unfortunately, most of this initiative was really not heeded, both by the WHO and of our CDC. And the one thing that when I look back and I think of what was the greatest failing we had in the pandemic, it's not realizing early on that this virus was aerosolized and then taking many, many years to even start to take steps in mitigation of these aerosolized particles. Even now, we're not doing it. Hospitals are still using surgical masks, which is rubbish. For example, this is a patient with acute tonsillitis. And let's say this patient is coughing. Well, coughing can aerosolize particles. The aerosolization of an airborne infection is produced by talking, singing, and even breathing. And so if you're seeing a patient with acute tonsillitis and they're coughing, they're going to be aerosolizing those particles. Now, they may be large droplets, but if you're close to that patient, examining the patient, you can get infected. And a surgical mask will not afford you protection. You need to be wearing an N95 mask, a PAPR, an elastomeric respirator. All of these will help to protect you. And of course, you have to worry about eye protection and be wearing goggles. Now let's talk about ventilation. This is one of the keys to prevention of infectious diseases of many types, not only MRSA, but also of SARS-CoV-2. A good way of measuring if there's adequate ventilation is using a CO2 monitor, and that's shown on the left-hand side. You'd like to have indoor levels below 700 parts per million. Outdoors, these levels are 450 parts per million. On the right-hand side of this picture, you can see a person who is coughing with a surgical mask. Again, that's probably going to afford some protection, but it's not great. N95 masks are what are needed to prevent spread of airborne pathogens. Surgical masks are just that. They're designed for the surgeon to wear during surgery to cut down on his spray that he has when he talks, from that entering into the surgical field. Now, the importance of ventilation was really underscored by Raymanatz et al. They published a paper in Nature Communications, and they found that for every 100 parts per million increase in PCO2, there was a 9% increase in detection of an airborne pathogen in the air. Now, the CDC has stated that you should have at least 5 air exchanges per hour in buildings, and that you should be upgrading your HVAC system to have a minimum efficiency, a minimum MERV efficiency of 13. However, I would like to see HVAC systems upgraded to where that is at 15, and we'll talk about that a little later. You need to inspect your HVAC systems, and you need to have portable HVAC filtrations, along with using UVC lighting. And this, I feel, should be done. It should be done in healthcare settings. These are recommendations for standard buildings. So healthcare settings, you want to be even more vigilant. So again, ASHRAE, which is the American Society of Heating, Refrigeration, and Air Conditioning Engineers, they've stated that a MERV 15 air filter is required to remove 85% of airborne pathogens. And prior to the pandemic, you wanted to keep the indoor air CO2 levels below 870 parts per million, but during the pandemic, you wanted it much lower than this. And so for me, I like to see it at 600 or 700. Now, one of the problems with MERV filtration, it puts a strain on the HVAC systems. Even going to a MERV 14 can induce stress. A MERV 15 can actually burn out your HVAC system, and so you'd have to upgrade your HVAC system. You then get into the problems of, well, you need an electrical grid now that's greater to support the higher energy used by the motor to drive air through the MERV 15 filter. And so all of this requires a lot of upgrades. It's not simply buying a $5 filter that you then replace in your HVAC unit. And that's one of the reasons why other types of filtration, either portable units or UVC filtration, is being advocated. But filtration is extremely important. For example, this is a study that was published in Frontiers, and Reuters has reported on it. And it was out of Italy, and they decreased school COVID cases by 82% by having ventilation that now had 6 air replacements per hour. And so that's unbelievable. And they showed a stepwise gradation with 2.4 times an hour replacement, 40% reduction, with 4 air replacements, a 66.8% reduction. And finally, when you got up to 6 air replacements per hour, an 82.5% reduction. So when it's airborne, we want to stress this means that it can be spread by shouting, singing, and talking. No distance is safe indoors. Even 60 feet is unsafe. Outdoors, aerosols will rapidly dissipate, but in crowded conditions, you can certainly spread the infection. And for aerosolization of an airborne pathogen, you do not need an aerosolizing procedure. Almost all pathogens are aerosolized with an aerosolizing procedure. For SARS-CoV-2, it's just talking, singing, breathing. So I've heard some infectious disease experts around the state saying, well, you just need an N95 mask for an aerosolizing procedure. Again, that's rubbish. Airborne pathogens aerosolize without an aerosolizing procedure. An aerosolizing procedure will aerosolize MRSA, C. diff, all sorts of different bacteria. So let's talk about masking. So masking is extremely important. Again, N95 masks, PAPRs, elastomeric respirators should be used. Surgical masks, like the picture shown on the right, are not adequate protection against airborne pathogens. Now, this is a table which I find very useful, and it was printed by the Rockefeller Foundation. And you need to remember that the times of exposure to infection are not absolute. They're just relative, because being absolute, you'd have to know the pathogen, its infectivity, and the amount of pathogen that's in the air. In other words, the dosage you're being exposed to. That's the dosage that's in the air. So we don't know these, but this table is important as far as relative effects. So let's look at the source wearing nothing. That's what's going to be important here. And we're now wearing a non-fitted N95 mask. According to this table, you have about 1.25 hours protection. You have double the protection if that mask is fitted. And of course, the difference between fitted and non-fitted with an aerosolized virus isn't really double. It's kind of like it either works or it doesn't work. So you want to always go with a fitted N95 if you can. But now look, compared to a surgical mask, you drop down to 30 minutes. Cloth mask, 20 minutes. And nothing, 15 minutes. But again, that's going to depend upon the viral dosage floating around in the room. Now let's look if the source is also wearing a mask. Well, if you're wearing a fitted N95 mask and the source is wearing a fitted N95 mask, you've got 25 hours of protection. That's an unbelievable increase in protection. 10 times greater protection. Again, if you're wearing a non-fitted N95 mask, 5 times greater protection. So you see a large amount of additional protection when the source is wearing the mask. And that's because you have now source control. But most importantly, source control will decrease contamination of the environment and contamination of your eyes. Remember, a face shield will not give you adequate protection with an aerosolized pathogen. So this was a study out of the Lancet. It's looking at face masks. Without a face mask, there was a 17% chance of transmission. With a face mask, 3.1. But look at eye protection. Without eye protection, 16% chance of transmission. With eye protection, 5.5% chance. So again, masks help. They're a layer of protection. Vaccines help. They're a layer of protection. But source control is key. And unfortunately, source control is something that's become very politicized, and it is extremely difficult to have patients wear masks. But we feel in healthcare settings, especially because we are dealing with immunocompromised patients, that everybody should be wearing a mask, a well-fitted N95 mask, preferable, non-fitted N95 mask next, and a surgical mask, which is fitted to the person's face, either with double masking or with some of these plastic devices, is a third choice. Cloth masks really are not designed to prevent infections with respiratory pathogens. Now again, this point I think is important. Surgical masks are not designed to prevent respiratory pathogen spread. They're not intended to protect the wearer. They're designed for use in surgery. And the handing out of surgical masks to me makes absolutely no sense. So let's talk about isolation guidelines. This is very depressing. Recently, the Washington Post reported that CDC is planning to drop the 5-day isolation guidelines for individuals who are COVID-19 positive. They have a positive COVID-19 test at the get-go. They don't have much symptoms. Fine, let them roam around in public. This, I think, is very ill-advised. This is going to result in a continued spread of the pandemic and of SARS-CoV-2 and exacerbation of our problems with long COVID. This is an article which was written in MedPage Today, and it was a commentary, and it stated that in 2024, today, we have so many more tools in managing COVID-19 than we have for other respiratory viruses, spanning from home tests, wastewater testing, and we have potential antivirals, highly effective vaccines, and a wealth of clinical guidance to manage cases. Well, I don't know what world they're living in, but I think this is well past reality and really very optimistic. Our antivirals are down to one, which is Paxlovid. There has been viral resistance, which has been noted in some of the viral DNA data banks. So if this is used widely, I would expect viral resistance to this medication to become clinically apparent. We really don't have other highly effective, well-accepted antivirals which can be used. The vaccines are anything but highly effective. Their effectiveness is measured in months, with avoiding hospitalizations and deaths. But even at a 70% avoidance of hospitalizations and even higher of deaths and 70% avoidance of long COVID, with repeat infections, this safety is easily being overridden. So again, we need to take precautions. We can't declare victory because we're nowhere near close to that. A recent study, which was posted from data using the U.S. Census Pulse Survey, found that 1 in 4 people in Florida have developed lasting symptoms from COVID-19. This is a map from this survey's website, which shows the states. And as you can see, Kentucky has a high incidence of long COVID, where around 28% of individuals have experienced long COVID, and you would expect at least half of those to have lasting symptoms. And this, unfortunately, is impacting our workforce. And when you hear about Sweden, Sweden does better than the United States, in my opinion, because they're better at hiding their data. And their true data is now coming out. An insurance company, which is the IF, is reporting that 1/5 of the residents are worried about suffering from exhaustion due to brain fog. And in the younger age group, the incidence of brain fog was found to be 32%, almost 1 in 3 individuals. And so this is extremely high. So this is not good. A lot of lasting symptoms. We're seeing this here in the United States. We're seeing it impacting our workforce. When I've talked to my financial advisors, my past financial advisor has brain fog. My mother's financial advisor is experiencing brain fog. All of this is very concerning. In the United Kingdom, there are 2.8 million individuals who are complaining of being inactive due to chronic illness. And that's an increase of 700,000 since the pandemic first started. And that corresponds to a 700,000 net loss of workers in the United Kingdom. In the United States, the Brookings Institute estimates that up to 4 million people in the United States were not working because of long COVID. That was in 2020. This figure, I don't think, has gotten any better. We are now seeing reports from other countries where this incidence is progressing. In the United States, we're kind of handling this problem by not counting. So when you look at isolation messaging, I think the CDC is giving a very confusing message, stating on one hand that there's an urgent need for COVID-19 vaccinations to ward off severe complications, and on the other hand, minimizing the disease by greenlighting the safety of asymptomatic spreaders mingling within our community. So again, to me, that's very disconcerting. So let's talk about MRSA. Again, there's another big push by some policymakers within SHE and ISDA that, in my opinion, are trying to state that isolation of MRSA carriers is not warranted, and even in some cases, MRSA infections. And this is ill-advised. And here is the statement which was published. It says that although contact precautions remain an essential practice, considerations have been provided for hospitals that have strong horizontal protective measures, and neither ongoing MRSA outbreaks nor high or increasing rates of MRSA infections or hospital onset MRSA positive cultures, and that choose to modify the use of contact precautions for some or all MRSA colonized or MRSA infected patients. That was a mouthful to read, but basically what it's saying is if you have strong horizontal precautions, a facility may choose not to have contact precautions for MRSA infected or MRSA colonized patients. Well, that's, again, I think rubbish. What in the world does the number of MRSA infected patients in a hospital have to do with the risks and exposure potential a healthcare worker taking care of an active infected patient? What difference does that make? The risk to the healthcare worker when they're taking care of an infected patient is not related to the number of people that are infected in the hospital. And the same is true for visitors and staff, which now may be exposed to these patients wandering around the hallway. And if we look at the private sector, isolation of MRSA individuals and screening on admission has not been widely adopted. There's been a small decrease in some hospitals as reflected in the average SIR, but during the pandemic, we had a marked increase of 17% of the SIR, which is the standardized infection ratio for bloodstream MRSA infections. Now, you can see in the second quarter of 2021, there was a decrease, but that was due to pandemic reporting problems. The VA, on the other hand, has noted a progressive decrease of MRSA infections from as early as 2008 up to 2022, and this was throughout the pandemic. This decrease was steady and it was persistent. They did not experience an increase in MRSA infections during the pandemic, and they have experienced over an 80% decrease of MRSA infections in acute care units. Now, some of the proponents of just let MRSA individuals roam around the hospitals have cited that, well, there was hand hygiene that was also implemented with the Veterans Health Administration, other protocols, and this is what's responsible. Well, this really is not the case, because in the VA, MSSA did not decrease, only MRSA. One would expect MSSA to decrease similar to MSA if these other interventions were the cause of the MRSA decrease. And this did not happen. You saw a substantial decrease of MRSA in the VA, but only a modest decrease of MSSA. And guess what? In the National Health Service in the United Kingdom, the same thing was observed. When they implemented MRSA admission screening with isolation decolonization protocols, MRSA bloodstream infections dropped 75%, but there was not a concomitant reduction with MSSA. So again, isolation is important. And we can also talk about the movement not to isolate if unvaccinated individuals have an exposure to measles. Again, this is ridiculous. This is being expounded by the Florida Surgeon General. It defies science, and he's basically saying that you do not have to undergo 21 days of isolation if your unvaccinated child has been exposed to measles in a school setting. Very, very distressing. This is not what CDC guidance states, and it's something that I think needs to be really reversed and not followed. And again, it follows a pattern of we're doing away with public health. We're not going to isolate for SARS-CoV-2. We're not going to isolate for measles. We're not going to isolate for MRSA. It kind of is following a pattern of minimization, and really it's going to be exposing our workforce and our population and our healthcare workers to infections and causing undue illnesses and even deaths. Now let's talk about enhanced barrier precautions. This is targeted at nursing homes. This again makes absolutely no sense. Contact precautions, as you know, is using gloves and gowns in isolation and N95 masks if you have an airborne pathogen. Enhanced barrier precautions are essentially watered down contact precautions. They are used primarily for nursing homes and other congregate settings, but one of the keys here is that residents are not restricted to their rooms. They're allowed to participate in normal activities. In other words, roam around the nursing home. That makes absolutely no sense because they're being applied to a variety of multi-drug resistant organisms, including Candida auris. With these precautions, gloves and gowns are advocated to be used for high contact resident care activities, but they are not being advocated for usage in low contact activities such as passing meds. Now, high contact activities would be, for example, showering and bathing, changing briefs, assistant with toileting, providing hygiene, etc. But other than that, precautions as far as wearing gowns and gloves are optional. Now, again, these are being applied to skilled nursing home facilities. They are being used for MDROs, but they're not being used if the resident has draining wounds or has diarrhea, and this would include not using them for patients that have C. difficile. But they are being advocated for carriers and patients who have CRE, MRSA, vancomycin-resistant enterococci, multi-drug-resistant Pseudomonas, and drug-resistant strep. And they're also being advocated for Candida auris. And that to me is very perplexing because the CDC has all sorts of warnings out about Candida auris, how it's a serious infection. Once you become infected, a third of the patients can die. It's often resistant to medications. It's becoming more common. It's hard to diagnose, and it's spreading in hospitals and nursing homes. They even had up a map which showed Candida auris infections. And as you can see here, data stopped December 31st, 2022. Again, in my opinion, out of sight, out of mind. We don't collect data. We don't have to worry as much about the problem. But recently, we've had an outbreak of Candida auris at UK Health Center. And this is quite disturbing. And for MRSA, originally, it was stated that these recommendations were based on data, but when you looked at the predicate data, they didn't support the recommendations. Now it's being stated that enhanced barrier precautions are being supported by expert opinion. Now, if you look at the study by Rodman et al., you cannot find support for enhanced barrier precautions. Now, two studies, Rodman et al. And Moody et al., have found that carrier rates of MRSA in nursing homes are over 29%, so it's a problem. And if you look at Rodman et al. For enhanced barrier precautions, the risks of contamination with almost any contact with a colonized resident is severe. For example, their low risk of contamination activity, that of passing meds, has an 8% chance of contaminating a worker's gowns. Well, let's do the math. If 25% of the residents have MRSA, it's a problem. You're going to have at least one person that you're passing medications to that's colonized. And if you pass medications to that person 3 times a day, 7 days a week, you're going to have 147 interactions, which will mean you'll have 11 transfers of MRSA to your clothes of a non-gowned healthcare worker each week with enhanced barrier precautions. That's if you're taking care of one colonized patient. Similarly, transfer of gram-negative bacillus is also the same, and this is data from Blanco et al. The chances of transfer to gowns is smaller, the chance of transfer being only 3.3%. The chance of colonization is somewhat smaller, but you would still expect a healthcare worker to have a 69% chance of getting contamination of their clothes each week. Again, that's an unacceptable risk for them to be taking. So the problem is with nursing homes is that even low-risk interactions occur so frequently that transmission can occur. So again, in nursing homes, you don't want to have people who have a pathogen or aerosolized pathogen roaming around a facility. You need to be wearing N95 masks. You need to isolate individuals that are colonized and then decolonize these people. If decolonization is not possible, then you need to cohort individuals with patients with compatible microbiomes. So you may well have to have nursing home wings or nursing homes that are specifically designed to house residents with compatible microbiomes and similar pathogens. But our current way that we're doing this, of just kind of letting it rip and everybody roam around a nursing home facility, is going to really give a false sense of security, and I feel give rise to maybe even more spread. Now let's briefly talk about chlorhexidine bathing. There was a recent study by Miller and colleagues, which was published in the New England Journal of Medicine, which gave the impression that chlorhexidine bathing was a great intervention in nursing homes to prevent spread and to prevent positive cultures with patients that were colonized with MRSA. Now, there's some caveats that you need to realize. First of all, the literature in the past is very conflicting and confusing on this issue. And in the Millers and colleagues study, in the intervention arm, they had personal training sessions, coaching calls, and a toolkit of protocols and training materials to train people in the intervention. They did not do this in the control arm. I don't know what your experience is, but in nursing homes and hospitals, bathing, even with soap and water, is something that needs to be, I feel, greatly enhanced. Now, a previous study called the ABATE study, and this was published in The Lancet, one of the authors, in fact, of the two studies was the same, encouraged best practices in the control arm. And they used chlorhexidine in the experimental arm, and they had a negative study. Only with medical devices, and that was an ad hoc evaluation, only with medical devices did they find a positive effect. But again, this was a negative study with chlorhexidine. So a bias was present in the Miller and colleagues study, and there was a positive result. But when that bias wasn't present in the ABATE study, the result was negative. Now, also, people will reference the reduced MRSA study, and the reduced MRSA study did not find an effect using chlorhexidine to prevent MRSA bloodstream infections. So that was a negative study. They had an ad hoc group that they analyzed that they called an antipathogen category, where they grouped everybody together, but the reductions in that group were in Candida auris and in commensal bacteria. So when you hear that, the reduced MRSA study showed that chlorhexidine worked in any bacteria, and you hear that often, that was a conglomerate group, and it mainly just worked in yeast and in commensal bacteria. And there's the references. So at any rate, that is my presentation. I will conclude here. I want to encourage everybody to get a vaccination and not have a long COVID Christmas. I think that's an important thing to do. To wear N95 masks, you need to wear those. If your employer doesn't provide them, you need to buy them yourselves and wear them. If they become difficult to wear for a long period of time, think about using an elastomeric respirator. OSHA requirements do require employers to allow the employee to wear their own. So OSHA will back you up on that request. So at this time, I will stop sharing my screen and see if there are any questions.